Hello, this is Dr. Lisa Sun, and this is the second module of the two-part session on stroke in infants and children. Today we'll talk about outcomes and treatment of childhood and neonatal stroke. Our first objective today will be to examine the outcomes after pediatric stroke. Once we have a sense of outcomes after pediatric stroke, we'll talk about the multimodal treatment of pediatric stroke. And this will include hyperacute therapies, rehabilitation, and stroke prevention. And finally, we'll discuss the challenges in pediatric stroke. With regards to the outcome of pediatric stroke, there's a prevailing myth about how well children with stroke do. But as you can see, most are left with deficits and the possibility of stroke recurrence. This brings to the forefront the need for ongoing development of more effective therapies. We'll talk specifically about the outcomes after pediatric stroke divided by perinatal stroke, which you can see with blue bars, and childhood stroke in the red bars. Fortunately, death is very uncommon after pediatric stroke. It's just about negligible after perinatal stroke and only occurs in about 5% of cases after childhood stroke. The most common outcome after pediatric stroke is permanent neurologic deficit. And this can entail a broad umbrella of different possible outcomes, including hemiparesis, language deficits, or cognitive deficits. After perinatal stroke, about 50% of children will have a long-term permanent deficit, though about 90% of those children will ultimately be ambulatory and be able to walk. After childhood stroke, about 60% of the time, there will be long-lasting permanent deficits. Epilepsy is also a common outcome after pediatric stroke, with a third of children after perinatal stroke and a quarter of children after childhood stroke having remote symptomatic epilepsy. Sometimes epilepsy in these patients can be quite refractory to treatment, and they can also have additional complications such as ESES, which stands for electrical status epilepticus of sleep. So epilepsy is something that needs to be monitored for in the long term in any child that has had a stroke. Fortunately, stroke recurrence is negligible after perinatal stroke. And if you recall back to the first module, we discussed that the reason recurrence rates are very low after perinatal stroke is that most perinatal strokes are related to a confluence of different risk factors that all occur around the time of birth and subside in postnatal life. For that reason, we don't tend to treat children after perinatal stroke with therapies such as antithrombotic therapies like Coumadin or aspirin because the recurrence rate is very low. That's substantially different when compared to childhood stroke, in which there's a 15% rate of stroke recurrence in the first year. Arteriopathy and congenital heart disease are stroke etiologies that predict recurrence, as well as high rates of transient ischemic attacks, or TIAs. So therefore, the diagnostic evaluation for causes of childhood stroke is very important so we can better understand how to prevent stroke recurrence in each individual child. Now that we understand that the outcome of childhood stroke can be poor and children can be left with lifelong deficits, it's important now to focus on treatment and how we can both prevent these deficits as well as promote repair and recovery in these children. In this diagram, you'll see that there's 4 main aspects of stroke treatment that we think about in order, but essentially simultaneously when a child comes in with stroke symptoms. The very first thing we want to understand is if these children are candidates for reperfusion therapies, things such as IV TPA or thrombectomy. And we'll talk in detail about the data and lack of data we have in children with that regard. Simultaneously, we're trying to understand how we can help these children protect the areas of their brain that are being hypoperfused but have not had an infarct. And the penumbra, or the tissue that is dying but not yet dead, is the focus of our neuroprotective efforts, which we'll again talk about in detail. We move on to repair and recovery very soon after a child presents to try to promote recovery as soon as is possible, because we know that in adults, early and intensive rehabilitation is very important to outcomes. And then finally, simultaneously, we're trying to understand why each individual child suffered that stroke so that we can understand how to prevent that child from having another stroke. We'll start talking about reperfusion therapies. As you likely know, TPA, or tissue plasminogen activator, revolutionized stroke treatment in adults in the 1990s. We know that very few of adults that present with acute stroke get TPA, but other interventions surrounding the need to deliver TPA rapidly have improved stroke outcomes for a vaster number of adult stroke patients. For example, development of comprehensive stroke centers and emergency management of acute stroke have drastically improved outcomes after adult stroke. There are far fewer data in children. There was a trial called the Thrombolysis in Pediatric Stroke Trial, or the TIPS trial, that attempted to study IV TPA in children. Specifically, the TIPS trial was a multi-center safety and dose-finding study of thrombolytics in pediatric stroke. Unfortunately, before the study could be completed, it was discontinued due to low enrollment. However, a lot of interesting data has come out of this effort, which we'll talk about now. In order to set up the infrastructure for the TIPS trial, many centers that were participating in this study were able to develop what we call a primary pediatric stroke center. And what was deemed necessary to be able to safely and effectively deliver IV TPA are the things listed here in this figure. Those things included at least 3 subspecialists dedicated to stroke, including a pediatric stroke neurologist, MRI stroke availability 24/7, including in children the ability to obtain a sedated MRI. It was necessary to have a stroke team, as well as order sets to include IV TPA both in the emergency departments as well as the intensive care units. At the beginning of the TIPS trial, as you can see in this graph, many of the centers did not have the capabilities listed here that were deemed necessary to safely and effectively administer IV TPA. However, by the time funding was withdrawn and enrollment stopped, most of the centers had everything that was needed to be able to deliver this specialized care to pediatric stroke patients. This is really a very important outcome of this trial, even though we were unable to get the data necessary to prove that IV TPA is safe and effective. It really did allow for discussion and implementation of the necessary components of a pediatric stroke center, so that all of the centers that were enrolling for this study, as well as other centers, can be set up to effectively manage children with stroke. Though we don't have prospective data on IV thrombolysis in children, there are many cases reported in the literature. As of 2018, there were 181 cases of IV thrombolysis in pediatric patients. One sub-study that came out of the TIPS trial was deemed the TIPSTERS study. And in this study, they looked at children in a registry that were given IV TPA. And using statistical analyses, they were able to determine that the risk of symptomatic intracranial hemorrhage after IV TPA given to children within 4.5 hours of stroke ictus was about 2.1%. And that's less than we quote for adults that we administer IV TPA to. So it seems the conclusion of this study was that IV TPA is probably at least as safe in children as it is in adults. That said, there are no good data on outcomes as well as dosing of IV TPA. Specifically, there's an idea that that is called developmental hemostasis, where children have different clotting cascades than adults with regards to the different interplay between different factors in the coagulation system. And therefore, it's unclear if we need to give more IV TPA or less to children to be as effective as an adult. Despite the lack of prospective randomized data, about 2% of stroke patients that present to pediatric stroke centers receive IV TPA. Thrombectomy for childhood stroke is also something that is being done more and more. There are no randomized controlled data in children, there are no devices specific for children, and the minimum age for thrombectomy consideration is debated. This is a picture of a thrombectomy that we did at our center in a very young child, less than 1 year of age. At the time, this was the youngest child reported in the literature to undergo thrombectomy for acute stroke. But since then, more and more children, even very young children, are undergoing thrombectomy. So what is the safety of thrombectomy in children? The recent Save Child study looked at the safety profile of thrombectomy in childhood stroke, and they found that the safety did not differ from the safety profile in randomized clinical trials for adults. And in fact, most of the children treated in this study had favorable neurologic outcomes. In a comparison, as you see here, of the modified Rankin scale in the Hermes meta-analyses compared to the Save Child's study below, you can see that there's an apparently lower proportion of poor outcomes in the Save Child study, though the better outcomes overall after pediatric stroke compared with adult stroke must be considered when interpreting these results. With regards to age, there's not been randomized prospective trials that look at differences in procedure-related complications and safety in young children compared to older children. However, in evaluating the literature and in retrospective analyses, there is not a significant difference in procedure-related complications of young children less than 5 years of age compared to older children and adolescents. However, there are some special considerations in children which must be taken into account. For example, for mechanical thrombectomy, the need to navigate smaller vessels with devices made for adults must be considered. The rule of 5 says that children 5 years of age and older have very similar sizes of their intracranial vessels when compared to adults. And therefore, it's likely that children over 5 years of age have similar technical considerations as an adult. However, in children younger than 5 years of age, there may be a higher risk of vessel rupture and vasospasm due to the smaller caliber of their vessels. Also important is understanding that the differences in the etiologies of childhood stroke compared to adult stroke must be considered. In children, arteriopathies such as Moyamoya disease and dissection are more common when compared to adults. The risk of mechanical thrombectomy is likely significantly higher when the vessels are diseased, with concerns including vessel rupture, vasospasm, and expansion of dissection. Endovascular aspiration has some of the same concerns and notably often requires a larger guide catheter and larger femoral arterial sheath. And this makes one consider that the femoral artery diameter must also be contemplated when deciding which technique is going to be used for thrombectomy in children. In addition, children have a much smaller blood volume, and so operators must aspirate with care. To summarize reperfusion therapies, IV TPA with regards to childhood stroke has no data on the efficacy in children, but it's probably as safe as in adults per the Tipsters trial. Endovascular therapies are also being used with increasing frequency in pediatric stroke And the published literature, which is not randomized and retrospective in nature, does suggest that there is a similar safety profile. Another consideration in children is that when stroke is due to sickle cell, the most appropriate acute therapy is exchange transfusion. Acute reduction of hemoglobin S is known to be beneficial in acute stroke in patients with sickle cell disease. Moving on to our other types of therapy, neuroprotection has the same principles in children as it does in adults. In select cases, we allow for permissive hypertension to allow for perfusion of the blood of the brain, even during an acute stroke. Normothermia, normoglycemia, and prompt seizure treatment are all designed to minimize metabolic demand. Repair and recovery is also very important, and we involve our colleagues in physical therapy, occupational therapy, and speech therapy early on in each patient's course. We also consider things like fluoxetine, which have been shown in some studies to improve motor outcome after stroke in adults. Rehabilitation is a key part of optimizing a child's quality of life and their functional capabilities. Pictured here are a number of different techniques which are currently used or being evaluated after pediatric stroke. On the left is a boy that is participating in constraint-induced movement therapy, where his strong arm is constrained in a cast and his paretic arm is forced to do different tasks. The child in the middle is undergoing bimanual therapy, where she's engaging in tasks that require the use of both hands. And new techniques such as transcranial magnetic stimulation are being studied to evaluate if brain stimulation can be used to promote repair and recovery after pediatric stroke. Once we determine our treatment plan for reperfusion, neuroprotection, and repair and recovery, we must complete a diagnostic evaluation to understand why a child has had a stroke so that we can prevent future strokes. This is one scheme that can be used to use a tiered approach to evaluate why a child has had a stroke. Our typical investigations would include a brain MRI with vessel imaging such as MRA, and sometimes escalating to other studies such as digital subtraction angiography to further characterize the vasculature. We will sometimes also move to vessel wall imaging if an arteriopathy is present and needs to be further defined. Once we have a confirmed stroke or suspected TIA, we then move to cardiac tests such as echocardiograms with saline contrast and EKG and cardiorespiratory monitoring, and blood tests, which we approach in a tiered fashion and include hypercoagulability workup and genetic testing, as well as things like lipid panel if the child is at risk for hyperlipidemia. With regards to perinatal stroke, have been a lot of studies that look at if a full hypercoagulable workup is needed for infants that have stroke around the time of birth. And 2 recent studies found that it is likely unnecessary to do a full hypercoagulable workup in children with stroke. Our protocol at Hopkins is to only obtain these laboratory studies if there is a family history of a clotting disorder or stroke in a young age, or if the child has other clots in other parts of the body. Secondary prevention is very important after pediatric stroke. In one study of the International Pediatric Stroke Study, as pictured here, the practice with regards to initiation of antithrombotic therapy differed by location and by provider. However, subtypes that were associated with anticoagulation use were dissection and cardiac disease. In fact, for childhood arterial ischemic stroke, Guidelines consistently recommend anticoagulation for cardiac disorders and arterial dissection. However, controversies about anticoagulation versus antithrombotics like aspirin persist for other forms of childhood arterial ischemic stroke. The general consensus is that some type of antithrombotic therapy should be continued for about 1 to 2 years after the stroke, but although that depends on the etiology. Management of cervical arterial dissection in children is similar to that in adults, with antiplatelet and anticoagulation having similar effects on recurrent stroke risk at 3 months. Some data specific to children show that after a dissection with stroke, 9% of children have recurrent ischemic stroke after diagnosis. In addition, after a first dissection, about 10% of children have recurrence of a dissection at another time point. In these children, it is really important to evaluate for connective tissue disorders or other risk factors for recurrent dissection, and to counsel the families on risk factor avoidance. Moyamoya arteriopathy is managed much differently than other causes of pediatric stroke. While most providers will recommend aspirin or other antiplatelet therapy in children with moyamoya, safety and efficacy data are lacking, and the true definitive treatment is revascularization surgery, which in children is typically an indirect bypass procedure. We don't have time to go into all of the aspects of sickle cell disease and stroke, but suffice it to say that multiple trials since 1998 have examined different ways to prevent stroke in this very high-risk population. The last thing we'll touch on is challenges in pediatric stroke. As I've mentioned multiple times, there's no randomized data for almost anything we do, and we generally are extrapolating from adult data. However, adult data may not be generalizable to kids due to developmental hemostasis, differences in stroke etiologies and risk factors, and ongoing brain development that may influence stroke recovery and ultimate outcomes. Finally, there is a very prominent lack of recognition that children can have strokes, and this often leads to delayed diagnosis. As many of our treatments for stroke are time-dependent, this delay in diagnosis can be really devastating for a child that has a stroke. To summarize the key points, pediatric stroke is a rare but very important cause of long-term neurologic disability in children, and it must be diagnosed and treated early to optimize outcome. Kids have a great capacity for recovery, but outcomes remain poor for many children. The concept of a primary pediatric stroke center has emerged to develop an infrastructure to optimize patient care. And finally, pediatric stroke faces many challenges, and a deeper understanding of the causes of pediatric stroke is needed to develop better therapeutic strategies. Thank you so much for tuning in to the second module of pediatric stroke, and I would be happy to answer any questions if you submit them to this email address listed here. Have a nice day.